So, just a little bit of context on why I think it's important to talk about implementation. So, some of you may remember a commentary that came out of the Canadian Medical Association Journal, and in this commentary, the author said that Canada is essentially a country of perpetual pilot projects. And what they were arguing in this commentary is that the way that we fund research results in a lot of pilots that don't actually make their way into sustained programs that we could see outcomes at the patient or at the system level. And this kind of method of funding projects that are really kind of stopping at the pilot and not thinking about long-term impacts and sustainability is actually doing a disservice to our health system. So, about 5 years after that, the Lancet journal published a series of articles around research waste, and they described what's called a leaky pipeline of research. And in this series of articles, they were essentially saying that the way that we're doing research is not necessarily the most efficient way. So, we're asking questions that might not be important to our knowledge users, might not be important to our patients, and actually missing the mark on what some of those health system priorities are. We're not looking at what research has already been done and trying to add to it, resulting in a lot of duplicated work and research waste. And when we are doing research, we are not always reporting exactly what it is we're doing, and we're unable to kind of learn from each other's successes and failures. And so what's happening kind of in the way that we're funding research and the way that we're conducting research is resulting in this leaky pipeline of research waste that's not letting us realize kind of the return on investment in research in terms of patient and systems outcomes. So, knowledge translation was seen as a potential solution to this problem. And so, knowledge translation or KT, there's a lot of kind of different terms floating around when I talk about knowledge translation. I'm using the Canadian Institutes of Health Research definition, which talks about a dynamic and iterative process. And within knowledge translation, it includes both the knowledge synthesis, so thinking about the quality of the evidence, the dissemination of that evidence, and then what's kind of the feature of our talk today, the implementation of that knowledge. So essentially, it's about putting knowledge into action at all levels of the health system in order to improve health. And along the way, we want to be doing what's called integrated knowledge translation, which is essentially doing research with the people who use it. And so these people are called knowledge users, and they can range from patients, caregivers, all different types of clinicians, policymakers, administrative personnel, etc. And we know that when we actually work with knowledge users early on, it results in research that's more relevant, more applicable, has greater likelihood for implementation success, and then greater likelihood to have impact at that patient and the health system level. And so the knowledge to action model, this is a planned action model that's rooted in theory, and we could use this to really kind of map out our steps of implementation. And the nice thing about the knowledge to action model, why I like it so much and why I think it works nicely with kind of learning health system framework, is that right at the core of the model, it emphasizes the need to have quality evidence. And so again, thinking about that research waste pipeline, we want to make sure that what we're implementing is actually rooted in evidence. And if that evidence is not there, that we're proceeding with caution and really kind of testing out our strategies before we kind of do any large scale implementation. At the core there is that funnel. And so the funnel essentially kind of talks us through all the phases of doing research. So at the very top is knowledge inquiry. So these are our individual randomized trials, our observational studies. These are our kind of bread and butter research studies. But it's rare that we're going to change our practice, especially at a large scale, based on the results of a single study. Instead, we want to really take time to synthesize the body of evidence around a specific topic. So we move into our next step of the funnel, which is around knowledge synthesis. So at this stage, we're doing systematic reviews, meta-analyses to appraise the overall body of evidence and to say, okay, we have confidence that the evidence is solid here and we can move on to implementation, or maybe we need to do a bit more research before any kind of broad scale implementation. And the last step of the funnel is really that bridge between thinking about evidence synthesis, dissemination, and then implementation, because we know that when we publish a systematic review or a meta-analysis, that won't really translate into uptake. So we have to think about the different types of tools and resources that can make our knowledge accessible to knowledge users so they could actually implement it. And so in that final funnel, we're creating things like decision aids, guidelines, policy briefs, infographics, so really tangible products that tell people exactly what it is that we want them to do. And so there are four key questions we can keep in mind when we're working through that action cycle. So the first question is, what is the evidence-based practice? So what specifically do we want people to be implementing? The second step is, who needs to do what differently? So implementation requires people to change their behavior, to change their practice. So who are all these different actors that are going to need to change their practice to facilitate the implementation? Next is, why would these people change their practice or not? And then finally, how can we support the practice change, or how do we facilitate the implementation of the what? And so I'm going to be using an example from a project called MOVES. MOVES stands for the Mobilization of Vulnerable Elders. And this was a project that was led by Dr. Sharon Strauss, who's the director of our program. So essentially, the MOVES team found a series of systematic reviews, including a high quality Cochrane review, that showed that when older adults are admitted to hospital, the first thing that happens is that they're put to bed. And in that time, we start to see a lot of negative outcomes. So we see increased hospital length of stay, decreased cognitive function, decreased muscle capacity, and that a lot of these outcomes can actually be prevented if we mobilize older adults early on and we mobilize them often. And so the goal of the MOVE study was to support the implementation of a mobilization program for older adults across Ontario hospitals. And so the first step, if we're thinking about our key questions, is thinking about, well, what exactly do we want people to do? And so when we when we talk about these methods, I often say, if you're stuck in an elevator with somebody and you have 10 seconds to tell them what it is you want them to do, what are the specific practices that you're going to tell them? So you're going to move beyond your goal. You know, it's not just, I want to mobilize older adults or I want to improve this outcome. We want to kind of drill down to the specific practices that when those elevator doors open, that clinician, that patient knows exactly what it is that they need to be doing. And that process is really defining our what using evidence. So in our MOVE study, there were three specific practices that we wanted to see implemented. The first is that we wanted patients to be assessed for mobility within 24 hours of being admitted to hospital. The second is that we wanted patients mobilized at least 3 times a day. And the third is that we wanted the mobilization to be progressive and scaled to that patient's ability. So once we've defined our what, we then want to think about all the different actors that are involved. So who's going to need to change their practice in order to get this implementation into routine care? So of course that includes physicians, nurses, occupational and physiotherapists, but it also includes patients. It includes caregivers who are now being asked to walk when they're admitted to hospital. So when we map out all of our who's, all of our actors, that really helps us identify our knowledge users. And then we can work with these groups of people to figure out what their needs are and to co-create our implementation plan with them. So the next step is to think about, well, why would these people change or not change their practice? And this step of really interrogating the why is really kind of the backbone to implementation science. And we want to make sure that we are not assuming that we know the reasons why change will or will not happen. And rather, we're using a systematic approach and a theory rooted approach to think about all the different reasons at the individual level, organizational level, contextual level, why behavior may change or not. And that's important for a number of reasons. First of all, it helps us make sure that we are not incorrectly making assumptions about, maybe it's a knowledge issue, maybe it's a capacity issue. We can be more assured that we're not skipping potential barriers and facilitators to change. But it also prevents us from contributing to this research waste. So now we're not going to be suggesting strategies that maybe aren't actually targeting the barriers that exist. We're not assuming that certain interventions are going to work when we haven't kind of done the legwork. So when we're thinking about why, we're really thinking about barriers and facilitators. Why would people change their practice? Why would they mobilize patients? Why would they not mobilize patients? And here we can really look to the implementation science literature to give us a series of practical determinant frameworks and tools to help us systematically think through those barriers and facilitators. And Jeanette will present a number of these to you as kind of easy to use tools and worksheets at the end of the session. So this is an example of a theory that's linked to some of the commonly used frameworks in implementation science. And essentially this theory, it's called the COM-B, which stands for Capability, Opportunity, and Motivation of Behavior. And essentially what the COM-B argues is that you need to have the capability to change, the opportunity to change, and the motivation to change. And if one of those components is missing, it's unlikely that your behavior change is going to be realized. So, thinking about the practices that you listed in the chat, what do you think some of the barriers to implementation might be related to your evidence based practice? Is it capability? Are people lacking the knowledge or the skills to implement the practice? Is it the opportunity? Do people not have the time? Does the environment or the physical space, is it not conducive to implementation of the practice? Are there potential social factors, cultural norms that are impacting opportunities? Or is it related to motivation? Do people maybe not think that this is very important? Or do they think that, there might be negative harms if they implement the practice? Or as Sarah highlighted, spot on, is it a combination of the three, which is often the case? So these are some examples of barriers that came out of our study. And when we did our barriers and facilitators assessment, our why, we actually talked to all the different knowledge users. So that's a really important piece of implementation is we don't just want to speak to the clinicians. We want to make sure that the intervention works for the clinicians, works for the patients, maybe works for the policymakers, and we really want to make sure we've spoken to all of our who's. And so these are examples from our clinician interviews, and they kind of highlight the range of barriers that were present with mobilization. The first barrier came from a physician, and this person said, "Well, it's not my job to move the patients. That's what the physiotherapists do." So we could advance the slides. So in this case, they felt that this was not within their professional role of practice. It was not in their kind of job description, and so that related to motivation. And they didn't feel that this was something that they were really eager to do. The next barrier, somebody said, "Well, I'm afraid that if I get patients moving, that they're going to fall. And now, we have fractures to deal with." So in this case, the person felt worried about what are the consequences of implementation. So this is actually going to result in a harm. And I don't feel that I have the skills to mobilize people safely. So again, we were able to kind of categorize that using theoretical frameworks and then mapping them back to theory. And I know in implementation, we often really focus on the barriers. It's just as important to use this process to think through the facilitators. And these are the levers that we can use to our advantage in order to support the implementation. So, one facilitator that came up in our interviews is people said, "Well, once I started encouraging patients to mobilize, many did it on their own. And it was really great to see those changes happen so quickly." And so, in this case, we saw these positive reinforcements almost immediately, which really motivated the clinicians to continue mobilizing patients. So using this process of again thinking about all the reasons why people would change or not gets us one step closer to now picking the strategies that will match those barriers and will leverage those facilitators. So in terms of the strategies that we could use, how we're going to bring about the change, these are methods or techniques that could be used to enhance the adoption of a practice. And there's really an art and a science to picking these strategies and operationalizing them. There's a quote by Richard Grohl in the BMJ, and he says that evidence-based medicine needs to be complemented by evidence-based implementation. And so when we're picking these strategies, there's kind of a few things we want to keep in mind. First is we want to make sure that they're rooted in theory, that they're actually going to tap into those behavioral components we identified. Second, we want to use the body of implementation science to operationalize these in the most meaningful way. For example, if we pick an audit and feedback intervention, there's a whole wealth of literature out there in implementation science about what is the most effective way to implement an audit and feedback intervention. And we want to be using that evidence to inform our practice. At the same time, recognizing that we want to work with our knowledge users to make sure that things make sense in their context. So again, we don't want to fully design something only to take it to people and realize it doesn't work. We want to co-create and think about sustainability really at the onset. So these are examples of different knowledge translation strategies, implementation strategies, many of which I'm sure look familiar and you may have used in your own setting. And but these include things like audit and feedback, communities of practice, educational materials, and local opinion leaders. So again, it's not that these are necessarily, novel strategies that you may not have seen before. The key here is making sure that we're picking the strategies that match the barriers and that we're operationalizing these in a way that aligns with evidence and a way that aligns with user needs. So, in terms of the strategies that we created for the mobilization program, we actually had a multi-pronged strategy, which is often what we do in implementation science. And so, for our setting, we had educational sessions for clinicians. We had educational materials, some that were patient facing, some that were clinician facing. We used reminders, and we also used mobility champions on the floor who really promoted the uptake of the intervention. And so, just to kind of summarize the key points here is that the most important thing is that our implementation strategies must match the barriers. And we could use implementation science frameworks to help us kind of think through all of those whys and then to pick strategies that will correspond to those barriers and facilitators. And what we want to avoid is the Islagiat phenomenon, or what's coined by Martin Eccles as it seemed like a good idea at the time, right? And so very often we have these really great ideas for an app, for a webinar, for an educational session, and only to realize that maybe we're actually not addressing the behavioral domain where the key critical barrier is. And maybe it's actually not about knowledge. Maybe we need to actually restructure the workflow or the process. And so taking that time to really think about that why and that how will again help our implementation success, but also reduce the likelihood of us contributing to that research waste. And so I'll make a plug kind of in advance of your next session, which I think is focused on evaluation, is along the way, we really want to be evaluating iteratively to think about what happened and why. And we want to evaluate the quality of our strategy. So how well did we implement these strategies? And if we implemented them well, did we start to see signals in behavior changing? And if we started to see those signals, did that actually result in changes in practice? And if so, did those changes result in patient and system level outcomes? And so the next slide just gives us an example of thinking about kind of an evaluation map for our study. So we started by thinking about, okay, how well did we implement our program? So how many clinicians participated in the educational sessions? How well were our reminders implemented? Did they resonate with people? And if this was done well, did we see improvements in knowledge about mobilization and skills? Were people more aware about why it's important to mobilize older adults? And did they have increased intention to mobilize older adults? And if all of that was kind of tracking, did we then see actual translated improvements in our mobilization rates that then resulted in decreases in cognitive decline, loss of muscle function, length of stay, and increase in patient satisfaction? And the important thing about evaluation, again, I kind of keep harping on this, but it really avoids our research waste and our effort waste. So we don't want to be 3 years into an implementation program, a QI program, only to realize I actually didn't see changes in mobilization. Early on, if we're evaluating, hey, nobody's actually showing up to the education sessions, or people don't really seem to like the audit and feedback, we can iteratively revise and change our strategies. And then that gives us confidence if things are going well, that we should start to see signals at that next stage. Are we seeing improvements in knowledge and skills? And if not, do we again need to go back to our implementation and revise something? So again, implementation is very iterative, it's very dynamic, and the evaluation really helps us make sure we're on track so that we can either go back and change what we're doing or feel confident that we're on track for implementation success and to explain to others why implementation was successful or not.